Hi, this is Dr. Matt Wynia from the University of Colorado. And again, this is number 3 in our 3-part series on navigating ethical challenges in public health emergencies. And today we're going to be talking about the issue of scarce resource allocation. So rationing of scarce resources. When there's not enough for everyone, how do you make decisions about who's going to get the resources that maybe multiple people want? These are the same disclosures. This is funded by ASPR, but not the official policy of any part of the US government. It's my own personal thoughts on this, and I do not have any conflicts of interest to disclose. We've talked in the 2 prior iterations of this about responsibility to care despite some level of personal risk, the duty to treat. We've talked about things like quarantines and mandates. And today we're going to talk about crisis standards of care and contingency standards of care and issues of resource allocation. And the big points we're going to make today are around proportionality, which is a critical principle, and the possibility of staying in contingency care, which we'll get to as much as possible. That multiple values are in play, as we've said in earlier sessions. This is not just about saving the most lives as a single principle. There are more issues that are at stake here. Rationing is not something you choose to. It is something forced upon you by the circumstances. And there are cognitive barriers to acknowledging when rationing is happening. One way to address those cognitive barriers is to acknowledge that, in fact, the ethical and legal standard of care does not actually change when you're rationing care. It's the quality of care you are able to provide that is changing, but your ethics do not change. And finally, we'll complete with some reasons why, if at all possible, you should not do rationing alone. This is not something where a single doctor at the bedside should be making that decision. The principle of proportionality is the one that says use the least restrictive means to achieve the goal. So don't use a sledgehammer when a fly swatter will do. What that means in terms of resource allocation dilemmas is you want to use the rationing strategy that is the least limiting as possible. So staying in what they call contingency care strategies for as long as possible, and be ready to revisit decisions as circumstances evolve. And this is my favorite example of that, which is after Hurricane Katrina, there were a number of people waiting for evacuation at Louis Armstrong International Airport. They were tagged with rationing, tags, triage tags, and some of the people on these stretchers had black tags. Black tags are given to people who are anticipated to die even if you evacuate them. So they go on a lower tier in terms of evacuation priority. But it turned out in the end, very few of those people with a black tag ended up dying in the airport. The vast majority ended up being evacuated. The reason for that is they kept coming back to them, and some of them changed the tag because they were, doing better than anticipated. Other times they came back and said, we have additional seats available on an aircraft, and so it became possible to evacuate them. So both the resources can change and things can happen to the individual that make it important to continue to reevaluate your strategy. The second major point I want to make is that there is a common sort of assumption that there's a major principle that really guides rationing, that everything else is secondary, and that is saving the most lives, right? So you get people in line, and the person who is most likely to have their life saved should be the first one, and then the second most likely is the second one, third most likely is the third one, and so on. And that's the lineup for how you allocate resources. And that principle of saving the most lives is the most important. There are 2 sets of reasons why this is an oversimplification that unfortunately doesn't work very well. So first, let's start with the pragmatic considerations. If you say your priority is to just save the most lives, what does that actually mean? Do you mean saving literally the most lives? So a 5-year-old is the same as an 85-year-old, someone who, is dying of pancreatic cancer and is very likely to be dead within a week. Someone in hospice care, that person should get the exact same priority as a newborn, right? What do you really mean? Are you talking about saving the most life years? Are you talking about the most productive or quality of life years? And even if we had a a shared understanding of what saving the most lives mean, which we might be able to come to, what data do we have to make those calculations? Who gets to make those calculations? How reliable are we at developing algorithms that rank order people in their likelihood of survival or mortality? And as it turns out, at least in COVID, we were very poor at deciding who using those kinds of algorithms. The other reason why it's unwise to assume that there's a single overriding principle is that there are, in fact, as human beings, other principles that matter. Things like equity, right? What if by saving the most lives, you ended up diverting resources away from the most hard hit, most vulnerable community? Many people would not feel good about that. What about resources being devoted to trying to protect the future, right? If by saving the most lives you destroyed trust in the healthcare system within the community or a community, would that be worth it? Right? So there are other values here. Respect for the dying is another one that comes up a lot. We don't actually put a black tag on people and then just walk away and give them no pain medicine and no attention, even though that pain medicine and attention might go to someone else who has a possibility of surviving. The fact is, we value giving people respectful care even as they are dying. So there is not a single principle that can or should take precedence in all cases. The reality of scarce resource allocation is that it is much more complicated than that. We do not have a computer where we just pump in data and get the answer out the other side. The second point I wanted to make, a third point, was that rationing is not something that is done by choice, but it is often done implicitly without acknowledging that we are rationing. These are two examples of this from the COVID-19 pandemic. On the right-hand side is the association between caseload surges and COVID-19 survival in a large number of hospitals across the US. And what the authors showed was that about 25% of the people who died from COVID during surges would not have died had they shown up at the hospital with COVID when it was a non-surge time. What that means is those people were getting lower quality of care during the surge. But of these 558 hospitals, a vanishingly small number ever said that they were actually rationing care and that they were in crisis care mode. They were in a crisis, but they never acknowledged publicly that what they were doing was rationing of care that was leading to additional mortality that would not have taken place otherwise. The same thing took place in New York City during the spring, the early spring surge of COVID in 2020. And these are data on the left-hand side here that show that if you were 25 years old, on the top set of graphs here, the gray bars are the surge. So the peak of the gray is where there were lots and lots of patients showing up to the hospitals with COVID, and the lower ones are where there are very few before and after the surge. And as you can see, if you were young, your odds of mortality, which is the red line, stayed about the same, whether you showed up at the hospital during the surge or after the surge or before the surge. As you get older, though, if you are under box E, 75 years old, you can see that your odds of dying rise quite dramatically from around 10% to around 20% if you showed up during the surge. So your odds of mortality were doubled if you showed up at the hospital with COVID during the surge. So this suggests that what was happening here was rationing was taking place by age. Older people were having services withheld, presumably in order to give those services to people who were younger. And the consequence of it was that there were older people who died who might have survived had that not had to take place, but it had to take place, right? So I'm not saying anything was done wrong here. These are just the data showing that, in fact, rationing of useful care, life-saving care in some cases, was in fact taking place during the pandemic, something that we all know as clinicians. The reason that none of these hospitals, the state of New York also, never declared crisis care is because we have a strong intrinsic resistance to accepting that rationing is taking place. And for evidence of this, I'll actually reach outside of COVID. This is when dialysis was first being rolled out across England in the 70s and 80s. This study went, at this time, there were not nearly enough dialysis machines to treat everyone who could benefit. But when they interviewed directors of renal units, few of them, less than half, acknowledged that there was a shortfall of available spaces. They mostly claimed that they were not rejecting any referred patients. They were taking everyone who had a medical indication, who was medically suitable. In other words, as they conclude, a process of rationalization was occurring in which medical indications were unconsciously being determined by what resources were available. And I expect the same thing took place to a large extent during COVID. There are a bunch of cognitive barriers that make it hard for us to admit when we are rationing care. First of all, saying you are rationing care makes you a messenger of doom. So people are reluctant to say it even if they think it, because of this phenomenon of others then going for the fire alarm rather than the fire, right? So attacking the person who calls attention to this unpleasant fact. We also have a strong impulse. This is from a JAMA paper during the pandemic that really laid out a number of cognitive barriers to acknowledging that we were operating under crisis care conditions. We have an impulse to save identifiable victims, less so to prevent potential future victims, especially if by trying to save those future victims, we end up withholding services from someone today and creating an identifiable victim. We have an optimism bias, hoping things will not continue to get worse, hoping they're about to get better. We have a present bias for helping someone today over helping people tomorrow. And we have a strong preference for accepting harms that might arise if we don't do something rather than harms that might arise because we did something. So this all gets to how we make decisions about resource allocation during a time of resource scarcity. And as you all know, there's sort of a spectrum here. There's normal circumstances, and at the far end, there are no available supplies, infrastructure is destroyed, and there's catastrophic failure, and you really can't provide care at all. But in between is a lot of gray area, right? So when you are early on, you are conserving meds, maybe you are electively discharging people whom you think are safe to discharge, you're bringing in your reserve staff. You're all still here, though, in conventional operations. At some point, though, you start to get into what are called contingency operations, where you are doing things that are acknowledged to be lower quality care, but you're hoping that people are not being harmed by this, right? So people are now being taken care of in hallways, and you're asking staff to perform tasks that they don't normally perform. And at some point, you do get to crisis operations, where you are activating triage protocols, where you are asking lay volunteers to perform things that a licensed professional would normally have to do. The problem is, none of these have a clear dividing line. They're all gray. And we are very reluctant to acknowledge that we've gotten to the crisis operation stage. Most of what we do, we would like to keep in the contingency operations, where it may be higher risk to give someone lower levels of dialysis so that you can fit more people on the same using the same dialysis machine. But that is preferable to saying we're not going to give you dialysis and we're going to give you normal dialysis, right? So that's what we end up doing, is operating in this contingency space where we know quality of care is not as good as it normally is, but it's as good as we can do right now. This is reflected in the National Academies, which was called the Institute of Medicine in 2009 when this Crisis Standards of Care report came out, where they really emphasize, and I underlined it here, but they emphasize that the definition of crisis care is a substantial change in essentially the quality of healthcare that you are able to provide, which is made necessary by whatever the disaster is. So that made necessary piece is really important. This is not something you are choosing to do. It is something that is forced upon you. And this is where we get to what we mean by standard of care. The ethical standard of care, as the IOM report articulated in 2009 in the red box at the bottom here, ethical norms, ethical standards do not change even during disasters. We are always obligated to do the best we reasonably can under the actual circumstances. That is the standard of care. So the legal and ethical obligation is to do the best we can given our circumstances. A disaster is not normal, right? That is not the normal circumstance, and it can become impossible to attain usual levels of quality in operations. So as the Joint Commission puts it, the aim in a disaster is to gracefully degrade the quality of care that you are delivering, not to suddenly stop providing services, life-saving services to one whole category of people, but to say, how do we use what we've got in the best way we can to save as many lives as we can while also attending to those other values like equity and so on. This also gets to some of the oversimplified ways that we often talked about this before the pandemic. This is a lovely set of slides from Anuj Mehta at Denver Health. We often would sort of have these thought experiments about, well, what if these 4 different types of patients showed up and you only had 2 ventilators? Who is going to get those 2 ventilators, right? And who is not going to get those ventilators? And that was the thought experiment. It's a lovely thought experiment, but it is not how this actually works, right? What really happens is you may think about this in advance. You may have a team of people saying, okay, so we're getting short on ventilators. Here's how we're going to allocate those ventilators. We have these criteria. We have a triage score. And then you have someone come in who meets that score, and so they get the ventilator. And then maybe someone else comes in who doesn't meet the score, and so they don't get the ventilator. And then you have a third person who comes in who meets the score and gets the ventilator. And then you have a fourth person who comes in and you've already got both ventilators used. Now what are you going to do? And this is a much more challenging question than the thought experiment about who gets it and who does it. Because now the question is there something you can do to actually get a ventilator to this person? Does that mean taking someone else off who's been on for a while and doesn't look like they're doing well? Does that mean, using a travel ventilator for a while? Does it mean having someone, a medical student ambu bag that person for a while? Those are the actual operational considerations that end up happening. And so this is one reason, by the way, why that notion of having an algorithm where you just pump in some numbers and it tells you who's going to get the ventilator and who's not is very unworkable in the real world. And this is why during the pandemic, the Critical Care Physicians Society came out with a statement essentially saying, stop trying to use the SOFA score as the sole predictor of outcomes that you will then use to make decisions about who's going to get what service. It also gets to the question of, oops, sorry, I meant to, oops, meant to put this up. So this is the statement from the critical care physicians about who should get these services and not using SOFA as the criterion for allocating resources. It's just simply not accurate enough. It's not a useful basis for triage decisions based on the SOFA score cut points. This then raises the question of, so how do you make these decisions if they are so complex and if there are so many variables that need to be taken into account? And if you don't have a simple algorithm where you ask a machine to do it? And this is where I would say, try not to do this on your own. Those values for the reason those formulas for reasons we've said often don't work. Even if the only thing you're trying to do is maximize saving the most lives, they just are not reliable for that. Bedside teams could make these decisions, but they have ethical and legal obligations to be advocates for their patients. And we actually don't want to lose that. The value of having your doctor be your advocate, having a nurse be your advocate is very valuable. And bedside teams usually lack the situational awareness that is actually necessary to make the best possible triage decisions, right? So they may not know that there are resources available elsewhere in the hospital, elsewhere in the healthcare system, elsewhere in the state, or around the state. Right. So the triage team really should be a group of people who have insight into the whole situation and not just the situation on the one unit where this one patient is, where the team is facing a decision. You can also, through blinded review, help to avoid some of the things that we know as human beings tend to bias our decisions about resource allocation, things like the color of a person's skin or what kind of a job they have, or if they're unhoused, or, a member of the local community is a priest at the local church. Those kinds of things do tend to, whether we want them to or not, they tend to influence our decisions. But if you have a triage team, they actually can receive clinical information that is critical, and whatever else information is decided is actually important to making the decision, but they can avoid getting information that is not necessary to the decision but may be biasing. So the bottom line is that a team doing this work can be more aware of the situation and better able to make ethical choices in these complex and frankly tragic circumstances. So to reiterate, the key points today are that proportionality is a critical principle. Don't just make a decision and walk away. Only stay in contingency care for as much as you possibly can. There are multiple values in play, not just efficiency. Rationing is forced upon you. It is not something you choose. And there are many cognitive barriers to acknowledging when actual rationing of potentially very beneficial care is happening. It is helpful to think about this, that the standard of care does not change. It's the quality of care that has to. And try, if at all possible, not to do this on your own. So that concludes this three-part series, and I look forward to hearing from you. These are my contact data, and thank you for listening, and I'll look forward to seeing you. Take care.